Good evening, and thank you for joining us for the Dean's Lecture Series featuring Secretary Kody Kinsley this evening. I'm Katie Bowler-Young. I'm the Assistant Dean for Communications, Marketing, and Business Development at Duke School of Nursing, and I just want to welcome you and let you know a couple of logistical details. Tonight's program is expected to be streamed in Spanish as well, and in a few moments, you should be able to see an icon in your Zoom screen that will give you the ability to turn on Spanish interpretation. There's a live interpretation that will be available. And now I'd like to turn this over to Dean Ramos.
Thank you so much, Katie. So thank you to all the members of the Duke University School of Nursing community, as well as our colleagues across campus and in the field of healthcare joining us this evening. I am Vincent Ramos, Dean of the School of Nursing and Vice Chancellor for Nursing Affairs at Duke University. And I'm so excited to be here together for the second lecture in our Building Upon Excellence Dean Lecture Series. The Dean's Lecture Series features prominent speakers throughout the academic year to connect our Doosan community, alumni, school partners, and friends with experts and educators on topics that address the role of nurses in the transformation of healthcare, highlight new nurse-led models of healthcare delivery, and help define the future of nursing education and research at Doosan. It is my great pleasure to introduce our guest this evening, Kody H. Kinsley, Secretary for the North Carolina Department of Health and Human Services, who will address health leadership and policy, give us an update on the COVID-19 pandemic, share DHHS's strategic priorities for the future, and talk about the department's commitment to investment in community and whole person health, a commitment that we at Doosan also share. Kinsley has years of public policy experience from the highest levels of state and federal service. At the federal level, he's held roles in the White House and served as Assistant Secretary of Management at the U.S. Treasury Department. He now leads the North Carolina Department of Health and Human Services as Secretary, where he previously served as Chief Deputy Secretary for Health and Operations, lead for North Carolina's COVID-19 response. Our guest this evening is responsible for delivering improved health and well-being for all citizens of the state of North Carolina. One of my goals in joining Doosan as Dean has been the expansion of health equity, a goal very clearly aligned with Kinsley's charge as Secretary of North Carolina DHHS. Secretary Kinsley's perspective is taking up this charge, Secretary Kinsley's perspective in taking up this charge has been shaped by his background and experiences. As an uninsured minor growing up in North Carolina, Secretary Kinsley was determined to take on a role in public service from a young age. Now, as the first openly gay cabinet secretary in North Carolina history, Secretary Kinsley brings a perspective on diversity not readily inherent to past secretaries. Through these experiences and perspectives, he developed a pay-it-forward mentality and a true empathy for other North Carolinians experiencing the same circumstances. Growing up, he knew that North Carolina could do better. Now, in this time of transformative opportunity, he works every day to champion the successes he himself experienced and to improve the health of North Carolinians overall. Please join me in warmly welcoming the Secretary of North Carolina Department of Health and Human Services, Kody H. Kinsley.
Well, thank you so very much, Dean Ramos. It is a great pleasure to be here with all of you this evening. Thank you so much for taking a little time to visit with me and to talk about what we're doing in North Carolina to keep folks healthy. We're so glad to have Doosan's partnership in this work. And the vision ahead for us is so bright, and it is bright because we get to work together to make a real difference for North Carolinians. So let me take a moment here to get my technology right and pull up my screen. Okay, so this evening I will be sharing with you, as Dean Ramos shared, several key things. So first, I'll give you a little bit of an update on where COVID is. I know that's still on the forefront of many of our minds, and then try to segue into a conversation about real lessons that I believe that we learned in the course of COVID that I think parlay into our commitment to recovery and how we recover stronger as a state. At the same time, there are many serious transformations that have been underway that have been about our department's commitment to really driving value from our healthcare system. And I think we'll have a fun time talking about that a little bit, and then we'll save some time for questions. So looking forward to that conversation. So looking ahead, or actually rather looking back, our response to COVID-19 really centered around 3 priority goals. First, save lives. And a lot of underlying efforts in accomplishing that goal, and I don't need to tell you all about those. But first and foremost, crafting our operations and our policies and our guidance and response around saving the most possible lives. Second, protecting hospital capacity. Of course, part of that role being in saving lives, but ensuring that hospital capacity was available for not just COVID-19, but other emergent issues. And you can see some of the work there. And then finally, keeping kids in the classroom. We know how important social emotional learning, other aspects of the experience in the classroom is for children. And so wanting to make sure as we were deep into this pandemic that we were using our resources in such a way that would keep kids in the classroom while also reducing the risk of, as much as possible, of catching COVID-19, transmitting it home or to other students. Of course, the 3 big things that were our major tools in making a difference in these spaces were vaccines, boosters, and masking. You see here a number of other tools and strategies aligned to each one of these big priority goals. And I won't go through all of those, but cutting across all 3 of these things were the top line work around vaccines, boosters, and masking where appropriate. Now, of course, now we're in a bit of a posture shift because of the wave, and we'll talk more about that and our different tools that we have, which is a good thing. We continue to push forward here in North Carolina. So looking ahead, right now we do find ourselves in a place where our hospital and ICU trends continue to decline. Part of that goal of protecting hospital capacity kept us focused on how do we manage the collective risk of our community hospitals becoming overwhelmed. This has been an increasing challenge over the course of the pandemic. I think many of you will remember that early on, a lot of hospitals were able to really totally cancel electives or perhaps non-urgent procedures. They were able to shift outpatient staff into inpatient settings. And over time, because we needed to not defer care any longer, and also just because of the brunt and the impact that this whole experience has had on our healthcare workforce, those became more and more challenging. The amount of depth that we could pull from in our hospital systems to really surge and maintain and manage support became less and less over time. Our denominator was slipping away, even while at the same time, with these successive waves, especially the Delta wave and the Omicron wave, pushed our numerator to even higher levels. So it's a real challenge. You can see this a bit on the slide when you see the number of admissions. And I look at this and seeing the Delta, this kind of captures the Delta wave and the Omicron wave in one slide. And you can see that reduced severity of the Omicron wave relative to the Delta wave. So even though it was about roughly the same number of people admitted, the Delta wave was a much wider period of time, while the Omicron wave was an even sharper incline. And while several of those folks, not the same proportion of people, ended up in the ICU. So we were able to weather that. Again, because we had significantly more access to treatment and more learning and the natural kind of innate lack of severity of the Omicron variant compared to the Delta variant. Good news is that our early indicators, both our COVID-like illness and our influenza-like illness, ED visits, continued to decline. This is our surveillance network that we're watching very closely, and with those declines being almost at baseline levels when you look back since September of 2020 for COVID, the orange line, it's a good indicator that we're in a much better place now than we were. This will be an important indicator for us as we look ahead. We know that cases in and of themselves and testing becomes less and less reliable as a metric as more and more at-home testing is happening. There's some selection bias that plays out there. Our COVID-like illness is a much better, more solid passive data indicator, and wastewater is another key one for us. So this does look at case rates. The thing that case rates gives us a bit different than these surveillance indicators is a bit more of the ability to hone in on different demographic information we have been really intentional to keep equity at the center of our response. To achieve that, data has been really important for our case information, of course, our testing to get that case information, hospitalization, et cetera. Here you'll see that across all age populations, the numbers are coming together. I don't think I have it for this presentation, but I will tell you that when we have looked at our Black or African American or Latinx Hispanic communities in the height of the Omicron surge, you really started to see a pull apart in hospitalizations, significantly disproportionate number of individuals from our Black and African American populations ending up in the hospital, again, tying that back to a lot of chronic health debt, if you will, leading into the pandemic. And so I think when we see those separations, we, of course, in the midst of the pandemic, go after it with boosters and testing and early connections to treatment. I think what we became quite clear to understand is that the real systemic underlying issues of historic lack of access to the healthcare system, the fact that we have over 1 million people uninsured in our state, means that we started a pandemic with people that didn't have their healthcare under control and their health under control, or a lot of chronic diseases under control in the first place. And so there's lots of legacy issues that we'll talk about that we started to see in real time in the data. And that's been one of our big challenges in having conversations about how to manage this, because, fixing chronic health debt that accrued over decades in the matter of a single surge, there are limits. And so, those are persistent, and we have to continue to go after them. I am proud that we did close the vaccination gap nearly for all age groups across our Black and African American communities compared to our white communities. And actually in the Latinx Hispanic community, vaccination rates now are exceeding that relative to our white population. And so we have done good work there in that one particular measure, but we know presentation in the hospital is the compound number of a lot of other issues as well. I think as we look ahead, continued operational focus on masks and that last mile to treatment and testing is going to be really important as we continue to try to work to close those gaps. I actually alluded to this a moment ago. I did just want to, I've never thought I would be so excited about poop data, but I have really gotten overly excited about our wastewater data. Some of you will know that North Carolina was one of the first 8 states in the country to stand up our wastewater surveillance system. We're now up to 24 different testing locations, and we're going to be at 36 in the next few weeks. The sites are already sampling. We just haven't been submitting that data to the CDC. We're just doing some quality control there. But I'm really excited that this gives us early indicator information. And we know that, we'll start to see increases in our COVID samplings in our wastewater probably 4 to 6 days, even before the first cases are identified. It's a great passive metric. There are some limitations here. We've been intentional about putting it in municipal treatment systems as aligned ideally with CDC's social vulnerability index to make sure we're catching communities more holistically and keeping equity at the center of that. There is an urban skew here. Almost 50% of North Carolina is on septic tanks. And so there's a lot of insight that we miss, which is why when I think about leading indicators in the future, it has to be the composite of that COVID-like illness and our wastewater information to get a better understanding of where we're going to start to see peaks on this. So you can see here in this example on the slide, current monitoring at different points across and the kind of intensity where you see more recent versus before in that wastewater increase. So I think it's good overall. Our numbers continue to decrease across these sampling sites in the state. I've already alluded to some of this in our equity work, but I did just want to hone in on some of the specific things that we have done, and I think about outcomes, and then I think about the effort and what we've been putting in to get those outcomes and thinking about how we parlay that into future work. So, we have been able to reach over 1.7 million people served by our community health workers. This is the state of North Carolina's Department of Health and Human Services did not have an on-the-ground massive what I call retail infrastructure at the start of this pandemic. We have had to build this in partnership with a lot of nonprofits and community-based organizations. I'm very proud of our ability to contract with them, to inject funding and resources into them to grow as part of their mission through this work, and not just rely on their goodwill, but actually to invest for their work. And so community health workers going door to door, connecting people to vaccines, testing, and treatment has been a really great part of this puzzle. And a great opportunity for us to parlay and connecting people to care, community health centers, and other services looking ahead. Part of that work has been leveraging our NC Care 360 system, which some of you may know about. This is our unified resource referral mechanism that we had started, and we're very lucky to have had in place in the midst of this pandemic as a particular tool for getting people connected to the social drivers of health. You know, we've had a bit of a natural experience through, or a natural experiment through COVID. You know, leading up to this, we have been talking about investing in housing, employment, interpersonal safety, and food as the 4 key drivers for health. And then lo and behold, we find ourselves in a pandemic where individuals have to isolate and or quarantine, preventing spread, protecting each other. And what are the things that they need access to? They need access to food and temporary housing from time to time, and other supports. And so having these resources in place gave North Carolina a bit of a leg up, even while we were trying to catch up with the fact that we had so many people without insurance. We did, vaccinate over 14,000 people at our events dedicated solely to our equity outreach work. Those were specific events in various communities and specific outreach efforts. You know, we used intentional strategies like setting aside vaccination appointments specifically targeted or focused on individuals of color, from individuals from different communities, you know, to really essentially create a set aside to get those opportunities for people to have access. As I mentioned earlier, as we look ahead, continuing to close that gap and overcoming that chronic disease issue around equity, I think continuing to provide masks to people that are in higher risk as individuals now manage their risk and their own interpretation of risk, those higher quality, higher grade masks like N95s to individuals. We have pushed out, this is specific. It says 560,000 masks were pushed out. Those were specific. We've actually pushed out over 13 million N95s in the last 2 months, which was a great way to empty the warehouse. So, and we continue to get more of these resources and push them out to communities. And then, as I mentioned, food, right? If you are working, you're a frontline essential worker, and you don't have access to paid leave, and you don't have health insurance, and you don't feel well, you know, making the decision to stay home and not spread the disease is a really hard decision to make. No matter how much you love other people, you got to work, you got to have income, you got to have food. And so being able to provide these food boxes, connect people to temporary housing so they can isolate, protect their family members, were all really key for us to lead with equity in everything that we did. So as we think about kind of where we are in the pandemic and things are coming down, and I look back on the last 2 years, I really see 4 big buckets of things that we were able to build, right? I kind of think of this as the crisis-opportunity, if you will, in the midst of the pandemic, and things that we can try to build on. So one is strong collaborative partnerships. I think about the people on this call and our connection with Duke and Duke School of Nursing and a number of other health institutions and academic institutions across the state, collaborations and a depth of collaboration that we've never had before. And it goes even further into the community. Some of those community-based organizations that I spoke about, ranging to entertainment and sports leaders and the Hurricanes and the Panthers and local churches and faith leaders and all kinds of things that not our usual fare for the Department of Health and Human Services, but such an amazing asset in getting such a wide and dispersed group of folks to talk and think about health and drivers of health. Second is data, information, and accountability. We remind folks that pretty much at the start of the pandemic, I don't think any state had a communicable disease reporting infrastructure that was designed to collect negative tests, right? It became an interest point for society to know what percent of tests were positive. That means you had to collect all the tests, not just the positive tests. And historically, we only collect positive reportable cases. And so we had, 70, 80% of tests coming into the state early on with all these massive reportings that were coming in by fax. And we had people that were typing in things and all kinds of stuff. And now we've gotten to the point where we have, HL7 data infrastructure connections with every lab and local health departments, and all these things are coming in electronically. And not only we're getting case reporting into our surveillance systems electronically, but we're able in our data lake to understand what percent of those people end up in the hospital and were they vaccinated or not vaccinated, and a great deal of analysis in a trusted, safe, anonymous environment that gives us at a population level an understanding of the course of the disease, some early understanding about vaccine effectiveness, and other things, even though a lot more research has to be done. But it gives us an ability to understand what's happening on the ground and see through programs in a way that we've never been able to see before at the Department of Health and Human Services. And as I think ahead, I think about, simple things that sound simple but are harder to do. What number of 52% of people in Medicaid are pregnant mothers? What percent of those individuals are on SNAP or WIC? We know the importance of those programs and supporting mothers and the need for getting those folks on programs to support healthy babies and healthy families, and the power of food. Yet we do not have a systematic way of really comparing the data between these data sets that already live in our house. And so really scaling our data investments and our data infrastructure to be able to really use this information to understand what's happening. We have accountability here, and I want to, that was really important for us from an equity perspective. The fact that we were able to, North Carolina led the nation in requiring race and ethnicity and gender as reported fields for vaccination. And the data quality and consistency of that data that we had compared to other states was just night and day. But yet we were able to compare by zip code the percent of people that were vaccinated in that area, look at the providers that were providing vaccines in those spaces, understand the community-based organizations, were vaccine providers vaccinating on par with the community served? What did that look like? And then as vaccines were a particularly scarce resource, think about how to partner providers and community-based organizations to really scale that effort, make it more possible for us to achieve equity. So that accountability and transparency was transformational, and you could see the dials moving in real time just by having the sunshine on there. And I think it's such an important opportunity for us to scale that into other efforts to make sure that our reach is really connecting with various historically marginalized populations. Of course, all that data and all that transparency and all those collaborative partnerships were the foundation for what our key goal was, which was earning public trust. And we have, throughout the pandemic, done a number of focus groups and polling, and we have consistently gotten feedback that we were the #1 most trusted resource in the state for information about COVID, and that 70% of people usually responded very highly favorably to the information that we were sharing. And we want to maintain that public trust and continue to parlay that in a way that is meaningful to improve people's health. And last and not least is, with that data and with the public trust and everything that we were doing, a recognition that there are things we know and things that we don't know, and that we're going to constantly be humble, and we're going to evolve based off and adapt based off evolving science and research. And as we have gotten us this far through the pandemic, I like to remind folks that the tools we had 2 years ago were very different than the tools we had 2 months ago. And they're very different today. And we have to constantly decide, what are we going to do based off the situation, based off what tools we have available, based off the nature of the variant, and craft a public policy response and a public health response that protects people and gives people the tools to navigate an incredibly complex situation, and somehow boil that all down into 5 words or less. So it's a fun challenge constantly. So moving ahead a bit here is, as we think about the building on the things that we did and that we really grew in the course of the pandemic, 3 big areas of gaps really jump up at me. And I won't read through each of these slides, but the three areas are behavioral health, children and families, and workforce. On behavioral health, we know that we were at a crisis point before the pandemic in the number of people getting access to mental health services, substance use disorder services. We know children and families, we have had a generation of children impacted by this when their foundation of resiliency is already less than most others because they've not gone through traumatic events. And we've seen in the data a tripling of reports of anxiety and stress across the state's population, but those are disproportionately felt in our younger populations. And that's a real challenge for us as we think about how are we going to do more interventions and support for those kids, not just in programs, but also in actual services. And then finally, and I won't have to tell probably anyone on this call that workforce has been a real challenge. Again, before the pandemic, we were on borrowed time. I think we had a lot of folks in key healthcare roles that were ready for retirement who, with 2 years of this incredibly blunt force traumatic experience, have been pushed out of the workforce or have made choices to go in other directions, right? There were problems leading up to this. Individuals were stretched. And now we've seen that play out before our eyes, and we have to address the urgent and the long-term concerns here. We need to make serious investments for our nurses. Thank you for having me. For our direct support professionals, for CNAs, throughout the workforce for healthcare, we have to be really thoughtful because there is no health without you all. There is no health without healthcare workforce. And so it's so critical for us to invest in this space. So, as we look ahead, and I challenge our team and I challenge our state to think about how do we not just recover, but recover stronger, we have to invest in behavioral health and resilience. We need to think about prevention upstream and our crisis system that actually averts crisis, a data system that helps us understand where beds are available, how do we connect people to care sooner, how do we take on stigma, how do we try to regain ground around opioids and substance use disorder and addiction broadly. So many opportunities for us to touch people's lives in a space where every single life in the state is touched. Second, on child and family well-being, going back to that idea of SNAP and WIC and Medicaid, and how do we catch folks early in our programs to invest in them, to put people on a different trajectory for their lives, to put them towards more healthier and happier lives? How do we do interventions for children and families, especially those kids that have really complex lives where they're wrapped around the mental health system and the social services system and the public instruction system, and they have all these people and all these systems in their lives, but what they need is for these systems to work together around them as opposed to them being constantly tangled around those systems. And we can do so much more for that generation of kids and really put our investment in the future by focusing on kids. And then strong and inclusive workforce. I talked specifically about the healthcare workforce a moment ago, but what I would add to that is to say, we know work and employment is an evidence-based strategy for health. We also know that a healthy workforce is a productive one. We have the tightest labor market in a generation. We have an amazing opportunity to help employers invest in their employees, make them more productive and healthier, but also to connect people to employment that have been historically left out of employment. I'm thinking about people that are in recovery, who are never given a chance. I'm thinking about people with chronic diseases that need reasonable accommodations that are much more affordable than poaching staff from other places and are dedicated employees. I'm thinking about individuals with disabilities who we know employment first is an evidence-based strategy for their engagement in community, and it's good for the inclusive communities and it's good for them. So we have such an opportunity to really think about equity throughout all of this and in our workforce space. So I'm very excited as we think ahead. We are building out a number of efforts and objectives in our strategic plan. In this work, we'll be prioritizing. I am tenacious about wanting to get some stuff done for North Carolina, and these are our big three priorities that we are focused on. So let me take a step to some things that have been undergoing for some time, which is really in the context of our commitment for value. And this is about how do we use our dollars at the department. I have a $26 billion budget. We have a lot of different resources and programs. And this goes back to this idea of how do we wrap these programs around people in a way that gets more and better outcomes for them, and how are we being good stewards of the resources that we have? I think our big leverage points here are our money, our dollars, and our data. And so let's talk about dollars for a moment. So dollars is our shift to managed care, a tool that we believe that we can use to help improve the health of North Carolinians by using a whole person-centered approach and really bringing care around the mind and the body together in one, but also allowing investments in social drivers of health that really improve outcomes for people and hold everyone accountable to that, right? Everybody knows that this country spends an inordinate amount of money on healthcare with some of the lowest quality outcomes in health. And this is an opportunity for us to buy health as opposed to just buying care. So in the midst of the pandemic, our team went live with our first step into managed care. This is our standard plans. I'm very proud of their work. I'm grateful to the General Assembly who partnered with us in crafting this plan and this design to get us on this step towards value and on this path towards better outcomes. And so on July 1st of this past year, we went live with managed care and our standard plans. And for the most part, it has been relatively smooth. Payers, providers have been paid, things have happened, people have gotten their appointments met, et cetera. And so for as large of a transformation this is, I'm very proud of the team and how much work was done to make sure operationally it was sound. It's about 1.7 million people that are now being served in the Medicaid program through these managed care standard plans. We also have over 4,000 individuals in the Eastern Band of Cherokee Indians that are being served by the tribal option. You see here the regions across the state. And so we've got 4 statewide plans, and then we have one regional plan that works across a few regions so that people can have options. And every year they'll have open enrollment and they can choose what plan they want to be on based off of various things, that competition. Try to find a balance between competition for plans to try to get membership while also creating standardization, such as through our pharmacy and what things are covered to make sure that there wasn't going to be a lack of core services in any one plan. Our next step on our pathway to managed care is our behavioral health and IDD plans. We're slated for December of 2022 to go live across a number of regional plans. These will be very focused on serving individuals with more serious mental illness, IDD, or traumatic brain injury. And this will be an effort to really, once again, wrap physical health and behavioral health services into these plans. Much smaller population, about 175,000 people, much higher acuity and level of care needed. But we know that historically, these people have been served by plans that have not also been serving their physical health needs. And we know that if you don't invest in both at the same time, you don't get better quality and better outcomes for people. In the spirit of value and thinking about our dollars, I now want to talk a bit about our data. And so I mentioned already the Healthcare 360 or the NC Care 360 program as an effort to really use our data in a more systematic way. I worked for many years at a behavioral health provider in Western North Carolina. I remember being part of that team, and the best we could do for people was to hand them pamphlets and say, here, maybe these folks can help with your food, or here's a pamphlet and maybe these folks will help with something else. NT Care 360 that I referenced earlier is a unified solution that allows community-based organizations and providers to work together to help refer patients to services where it's a closed loop, safe, trusted mechanism for people to get feedback about those services getting fulfilled. So I'm really excited that that's on the ground and moving. And the Healthy Opportunity Pilot was a nationally recognized effort where CMS said, yes, you can use $650 million of Medicaid money to pay for those sorts of services: transportation, employment, interpersonal safety, and food. We've been particularly focused on food, and we are going live as we speak with this program. So we have pilot regions across the state that are going to actually be using NC Care 360 and being operated by our standard plan payers to help and other partners and community-based organizations to give folks access to food and these other drivers of health. And we'll be measuring over time both proximal and distal outcomes on the improved health outcomes for Medicaid members, with a particular focus on health equity and the pilots to make sure we're reaching people in an equitable way. And then ideally, again, what is good for health and people is also good for the pocketbook and investing in better value. So the pilot is launching, as I mentioned, really this month. You can see in very small print here, the different pilot regions where we're starting. This is a test on what we're doing in this specific program. And we're excited to see some of these domain areas come out. But as I mentioned earlier, our push towards value in the department is so much bigger than transformation in particular. In this Healthy Opportunities pilot, there's other data mechanisms and other ways that we're using to really use the full force of the department and our ability to wield better outcomes for people and wrap these services using our dollars and our data in a much more innovative way. So that really concludes me. Let me just sum up by saying thank you so much. I know I've loaded you with a whole lot of information, but I wanted to give you a sense of a few things. If you remember 3 things as you walk away from here, know that we really care about public trust. We want to continue to invest in transparency and invest in making sure we're all on the same page so that we can work together and leverage partnerships to make a difference for North Carolina. Second, that we will continue to use our data and our infrastructure and our dollars in a way that drive towards value and making a difference for people and making sure that we're good stewards and we get good outcomes for people. And then finally, those 3 priority areas: behavioral health and resilience, strong and inclusive workforce, children and family well-being. We're eager for your partnership in these areas. We thank you so much for what you do.
Thank you very much, Secretary Kinsey. I'm going to actually ask folks to start teeing up their questions in English or Spanish in the Q&A. And then while we're waiting, Secretary Kinsey, again, just want to say thank you so much for spending time with us this evening. A couple of things stood out to me as being really impressive in terms of places where there's synergy between Doosan and the work that you're doing at the state level. I think the first thing is the school is going through a pretty dramatic change in terms of how we think about our programs. And we are really grappling with how we can mitigate social determinants of health and not simply characterize them, but what are the actual levers that we can push to actually make a difference in people's lives. I think the other piece is this notion of nurse-led models of care and how can we think about shifting from the tendency to focus on people who are quite ill and advanced as being the sole focus, but really how do we disrupt those trajectories? How do we focus on wellness and prevention, and how do we think about whole person perspectives, as you mentioned? And I guess the last is around payment models, and if there are ways that by really thinking about barriers to practice and leveraging nurses at the full extent of their training and experience, are there ways that we can actually improve outcomes and save cost? And I think those are things that resonate with the audience that's here this evening. And so I felt like it was important to share that. We have a couple of questions from Patty. So the first is about wastewater. And so will wastewater testing continue to be expanded and funded?
Yeah, well, I'm so glad you started with my favorite data topic. And you can ask my team. I make an exceedingly number of wastewater jokes. Yes, absolutely. We continue to invest in this. And not only are we growing, as I mentioned earlier, we'll be moving to 36 collection sites. We will continue to find areas. We are limited just by having 50% of the state on septic systems, but we will continue to grow those collections and sampling. We continue to be a leader nationally in reporting that data to the CDC. We're also building out sequencing as part of that. So we're not only identifying early indicators where COVID is appearing in other places, but we're also positioning ourselves to sequence that data, to sequence those samples so that we can understand where new variants may be arising. And then we're also thinking about influenza and drug-resistant diseases as other potential things to be sampling for. So this is really a great example where we leverage the crisis-opportunity to push forward in space. And I'm proud of the team to have done this.
Thank you. So there's a question in reference to the 1 million individuals in North Carolina without insurance. And so the General Assembly, as you mentioned, is currently looking at the coverage gap in North Carolina and the possibility of expanding Medicaid. What would be the impact for our state if North Carolina expanded Medicaid? And how would this affect some of the priorities that you've identified in your talk today?
Well, thank you for asking that question. And I neglect having not said already, and it may have been on a slide, and I should have pushed further, that there isn't one thing that I mentioned that would not be made better by expansion. I mean, closing the coverage gap is critical. And look, I want to be very clear. It's not a magic wand. It won't fix everything. But if we can bring 600,000 people into care, and everything that you just said, Dean Ramos, a moment ago about getting upstream and getting to prevention and getting to be able to employ nurses as part of that strategy and investing in the drivers of health, all of that is made better by expansion. Both because we have created this incredibly dynamic design that allows us to innovatively invest in those foundations of health. And so getting more people into those programs is key to that. But also because right now we spend what few dollars we have for crisis services, whether that's behavioral health or urgent services around food and stable housing. We spend the few dollars that we have right now, we stretch it as far as we can. And in the behavioral health space, it's really just enough money to keep people in constant crisis. Try to remind folks, we have about $275 million a year to help support the uninsured behavioral health crisis system in the state. Last year, of that roughly million people uninsured, 100,000 of them got at least one behavioral health service. It's about $2,700 a person. Now, you don't get much care if you're in crisis. If your first visit is showing up in the emergency department or going to a crisis center, that's not a lot of resources to get you from crisis stabilized into prevention and on a path of recovery. And so that's our problem, is that we are spending all of our dollars at the crisis end, and we can't parlay, to your point earlier, we can't get to prevention unless we can get an intentional investment that allows us to really shoehorn our way back. And expansion allows me to take the dollars I'm spending on crisis and invest them in other things that provide employment, food, all those wraparound supports around recovery. But expansion would be transformational for those with substance use disorder or mental illness, but also young mothers and every other community we've been talking about.
Thank you. There's a question, Secretary Kinsley, on your thoughts regarding local district public health departments and how to leverage and amplify these partnerships for health improvement in your vision. And there's a comment that follows, just to provide some perspective in terms of the question. I think the role of local health departments is one key in improving community health. And we saw all they did during the pandemic. And they often go under the radar, and partnerships could be increased between primary care, health systems, and other sectors. Nurses can play a key role in amplifying these partnerships, connections, given their positions in primary care, public health, and comfort with cross-sector collaborations.
Yeah, this is a great point. I grew up in New Hanover County down in Wilmington. I received, as you mentioned in very generous introduction, I grew up without health insurance in North Carolina. I received all of my immunizations, not at a pediatrician, but at the New Hanover County Health Department. I still have the records. I received all of my dental care growing up as a child because the New Hanover County Health Department paid for a dental program for kids that had free school lunch, right? So it was a partnership between the school system in New Hanover County and the local health department to get me connected to care that I needed for my teeth. And so there's so much more that our health directors, our local health departments could do, but they need to be resourced and they need to be funded. And unfortunately, in the time that has passed since I was a young child going to local health department, the dollars have gone in the downward direction for those services. And we have seen the magic of our local health directors and our local health departments and everything that they have been able to accomplish in the course of COVID. They have been on the front lines in so many ways. And as we think about the future of public health, I regret that we have not seen from the federal level the type of investment that we need to see in our local health departments to allow them to really be that foundation for health. And we're going to continue to focus on that. And as I think about our strong and inclusive workforce, investing in our public health workforce in particular is a key goal for us.
Thank you. So related question, Secretary Kinsey. So first, a comment. So thanks for your comments on workforce initiatives and the work your office has done with workforce related to hospital care. So the question, will this initiative support the long-term care workforce?
Absolutely. I mean, again, we're looking at the long-term care workforce, not only in long-term care settings, skilled nursing facilities, adult care homes, but also our direct support professionals. These were all fields that were in crisis before the pandemic and have only been exacerbated by it. At the same time, the labor market has really tightened and taken off. And so we have a lot of folks, our rates in various spaces, whether private or public, have not kept up in allowing the wages necessary in those areas to keep in pace with jobs that are much less stressful and pay much more. And so we've got to address that. Really grateful for the legislature's investment in the last budget in allowing us to do some temporary bonuses in those spaces. Grateful for the federal government's investment in home and community-based services that allow us to expand some supports there. So there's a number of tools that we're pushing forward on, but we know that North Carolina is also aging, and being ready for the long-term care services and supports kind of wave that's coming there. We're not in a good posture, and we've got to get there.
Thank you. Interesting question about technology. So how is the state targeting the access to technology, internet, in order to use telehealth care for rural areas?
Now, this is a great question. And if he had the magic to do so, the governor would love to jump on right now, because there's no person more excited in North Carolina about investing in broadband than Governor Cooper. And he has been incredibly out front on trying to get more and more resources for North Carolina, and whether it's for education, as we saw when individuals were doing virtual classrooms, or leveraging telehealth. And I should have mentioned earlier that one of the other things that I am proud of in our response is that for our Medicaid program, we pushed our telehealth policy forward probably 10 years worth of work in 10 days time. The ability to have focus and to have resources. And now what we're told time and time again is we want every other payer to have the same type of telehealth program that you've got. And so we're really excited for the investments we've made there. But you're right. If you're not on the other side of that connection, doesn't work, or it's fuzzy, or it clicks out, it really renders what can be a very powerful resource very meaningful. It's not the fix all for everything, but broadband should be like electricity, a basic right for utilization and utilities. And so Governor Cooper and our entire team at the cabinet level is incredibly focused on increasing access there. There's been a lot of investment, and we'll continue to push forward.
Thank you. So a question, well, first a comment and some feedback for you, and then a question. So DHHS has done a great job in COVID surveillance. North Carolina Detect is one vital resource for the surveillance. So then the question, will there be consideration of funding North Carolina Detect with more secure and permanent resources?
Well, thanks for mentioning NC Detect. And as I mentioned earlier, NC Detect has really had to grow in the midst of this pandemic. We started with a reporting mechanism for cases that was really based off positives, and now based more on all samples. We have invested in other resources to allow kind of the compendium of contact tracing and other things to happen more virtually as tied to NC Detect. So now when cases of syphilis are reported, they kind of queue up contact tracing automation so that people can virtually put in their contacts and their close contacts. So, it's a great opportunity for us to parlay the investments we have made in NC Detect and the kind of compendium of tools to get to a much more, speed of life, digital reporting mechanism that will have spillover positive effects for other reportable diseases. So there's more to do there, much more modernization, and a similar storyline in our vaccine registry systems and all of that. We have made major investments. There's still more to do.
Thank you. So there are a number of questions. We're not going to have time to actually send all of them out or ask all of them, but there is one that I'd like to read. It's less of a question, more of a comment, but I think it's a great way to kind of start wrapping things up. So not a question, but a comment for Secretary Kinsley. From the start of the pandemic, the North Carolina Department of Health and Human Services has been so transparent, informative, and trustworthy, which isn't something friends in our other states have experienced from their leadership, and it's deeply appreciated. Thank you for this talk, and I hope that there are continued partnerships between your office and Duke University School of Nursing.
Thank you for that. We are, all in this together. And, at the beginning of the pandemic, I spent a lot of my time in the behavioral health space working hard on this before I took on kind of all the operational responsibilities. And I think our motto then and remains now that we're going to tell you when we know something, we're going to tell you when we don't know something. We're going to be transparent, try to keep everybody on the same page. We appreciate your feedback. And again, really, really appreciate the opportunity to be here.
Thank you so much, Secretary Kinsey. Before we end, I just want to take just a couple of moments to say thanks to all the folks in your office, the folks that actually work as part of the Department of Health and Human Services in North Carolina, our team here at Doosan, all the folks who put this together, and everyone that's on this evening. Thank you so much for caring about the school, the state, and the health of real people, families, and communities. Have a good night. And again, thank you, Secretary Kinsley.
Thank you.